So, esophageal disorders. So, first of all, we're gonna categorize what dysphagia is. Phagia means swallowing, and dys means uh, inability or improper lack of being able to swallow is termed as dysphagia. So the patient may present to you with two complaints. Either the patient is gonna say, you need to keep these two distinctions in your mind. First of all, the patient might either complain of the fact that whenever he tries to eat something, it comes out of his nose, or whenever he tries to eat something, he gets a choking sensation, or whenever he tries to eat something, it feels like it goes into the windpipe instead of the esophagus, so that results in choking and coughing sensation. So whenever this sort of presentation comes in front of you, or if the patient cannot speak or adequately describe his symptoms, the caretakers are going to tell you this story, that whenever we try to feed the patient, or whenever the patient tries to eat, the patient starts coughing, or sometimes the food comes out of his nose, and sometimes he gets difficulty breathing during the eating process. So if this sort of scenario comes in front of you, it means that there is inability of the patient to actually transfer food from the mouth to the food pipe. Basically, that is termed as oropharyngeal dysphagia. What do you mean by oropharyngeal? With, as the word states, oro means the oral cavity and pharynx means pharynx. So there is inability or neuromuscular incoordination, leading to the inability of the patient to transfer the food from his mouth to the esophagus, or the start of the esophagus. So basically, this is a neuromuscular coordination problem. So since it is a neuromuscular coordination problem, so you're gonna get this sort of presentation in people who have had a history of stroke. And since stroke results in paralysis of the voluntary muscles like of the tongue, that might result in improper bolus formation and improper transfer of the food from the mouth towards the start of the food pipe. Or the patient may have advanced dementia like Alzheimer's disease. In that case as well, neuromuscular coordination is affected in a way that the patient cannot properly transfer the food from the mouth towards the start of the esophagus. So this presentation denotes that the patient has oropharyngeal dysphagia. On the other hand, on the flip side, this is also dysphagia, but this is oropharyngeal. The other form of dysphagia is termed as esophageal dysphagia. What happens in this? The patient is not going to tell you that he has difficulty swallowing. He can easily swallow the food from his mouth towards the esophagus, but the transfer of food from esophagus to the stomach, that is the problem. So what is the patient going to say? The patient is going to say that I can swallow the food, but it feels like it gets stuck in the throat. So this is the presentation for esophageal dysphagia. What can be the reason or demographic for esophageal dysphagia? The patient might be developing esophageal cancer, that is resulting in stricture formation, stricture, no, narrowing of the esophagus. In such a patient would have a history of smoking or alcohol abuse. That can lead to either adenocarcinoma of the lower esophagus or squamous cell carcinoma of the upper two-thirds of the esophagus. Another presentation can be of a patient who has achalasia. How are you going to identify that patient? That patient might have a chronic history of GERD, because achalasia presents with a chronic history of GERD, and it is usually misdiagnosed as GERD, and then after some time, after the problem does not resolve with the use of medical therapy, you do a endoscopy and you find out that the endoscopy or a barium swallow, a barium radiographic picture that shows a bird beak, then you know that it's achalasia. Basically, achalasia is usually misdiagnosed in the initial phase as GERD, or gastroesophageal reflux disease. So that can be a presentation that can point you towards the fact that the patient might have esophageal dysphagia. So in order just to summarize, oropharyngeal dysphagia, a patient with a stroke history or advanced dementia; esophageal dysphagia, a patient with a history of chronic smoking, alcohol abuse, or chronic GERD. So these are the factors that point towards either oropharyngeal dysphagia or esophageal dysphagia. So we are gonna give this flowchart a read. It also summarizes all the findings really well. So oropharyngeal dysphagia, either the patient has stroke, advanced dementia, difficulty initiating swallowing. So it's gonna present with coughing, choking, nasal regurgitation of food. What are you gonna do in order to confirm the diagnosis? You're gonna do a video fluoroscopic modified barium swallow. What is this? So basically the patient ingests, tries to swallow a contrast material, and you radiographically see at what point during the swallowing process is the patient having trouble. So it shows the movement of the fluid from the mouth towards the start of the esophagus, and also points out where the problem is during the swallowing process that is leading to the inability to get the food down properly. Like if the patient has nasal regurgitation, you're gonna see that the patient swallows the contrast material, it's gonna be visible, and you're gonna see it regurgitating from the nose. Or if the patient has problem in the pharyngeal muscles during the swallowing process, you're gonna see that the pharyngeal muscles are unable to properly pass down the food. If the problem is during the epiglottis is not properly approximating to close the the windpipe, you're gonna also be able to visualize that the epiglottis is not closing properly, leading to the food being getting stuck in the windpipe. I'll show you a video of that. So this video shows a video fluoroscopic barium modified swallow. As you can see, this is the contrast material being swallowed by the patient, and it's visible as it goes down. So it's also going to point out towards any anomaly during swallow, and you're going to see the movement of the food accurately, and you can then visualize where the problem lies during the swallowing process. So if the patient says that the food gets stuck in the food pipe, and he feels that the food is not going down, that points towards esophageal dysphagia. What are your differentials gonna be when you feel like it's esophageal dysphagia? The first one can be achalasia, the second one can be malignancy. Malignancy and achalasia, how are you gonna then differentiate between that? Achalasia is usually, since it is just a contraction or inability of the lower esophageal sphincter to relax, it's gonna present at the start with inability to swallow both liquids and solids. So dysphagia is gonna be for solids as well as liquids. The patient is gonna say, I was just getting heartburn, and suddenly now whenever I eat, it feels like it gets stuck in my chest, and whenever I drink, it still feels like it gets stuck in my chest. That you can conclude is dysphagia to both solids and liquids. So achalasia is on the list. On the other hand, if the patient says that I had trouble whenever I swallowed solid food, it felt like it got stuck, and now whenever progressively as the time passed, whenever I swallowed liquid, it still feels like it gets stuck. Initially only solid food felt like it got stuck. Now it feels no matter what I eat, it feels like it gets stuck. So slowly progressive dysphagia from solids to medium solid foods to liquids. If the dysphagia is progressive in nature, then that points towards malignancy. What other things can point towards malignancy? A history of smoking or alcohol abuse, because alcohol causes adenocarcinoma of the lower esophageal sphincter, and the alcohol and the smoking causes squamous cell carcinoma of the upper two-thirds of the esophagus. So I also need to keep that in mind. And a person with a chronic history of GERD is also a risk factor for developing malignancy. So these three factors should point towards malignancy as well. So basically, progressive dysphagia plus history of smoking, alcohol, chronic GERD, you go towards mechanical obstruction, that is malignancy as a reason for esophageal dysphagia. On the other hand, if a patient just has rapid onset at the start dysphagia to everything, you can go towards achalasia. So if you suspect malignancy, obviously in order to confirm the diagnosis, you will have to do a upper endoscopy and visualize the lesion and take a biopsy, then do a histopath and confirm the diagnosis. Whereas if you suspect achalasia, you're gonna do a barium swallow followed by a manometry with endoscopy. Why are you gonna first do a barium swallow? The reason is that achalasia has a specific bird beak appearance of the esophagus, where the esophagus is at the point of origin, the esophagus is dilated, and at the point of lower esophageal sphincter, because achalasia is basically a problem with the inability to relax the lower esophageal sphincter. So that place is gonna be contracted and all this area would be filled with food. So this is the sort of appearance you get. So if you get this sort of appearance, then you have right, or you are justified to proceed towards the next test, that is the gonna give you the absolute diagnosis, that is the manometry. So then you perform a manometry. What does manometry do? Manometry basically tells you the contraction of the lower esophageal sphincter. It basically tells you how well the lower esophageal sphincter is relaxing or contracting. So in case of achalasia, the finding that you guys are gonna get is that of increased resting tone of lower esophageal sphincter. So this is manometry, basically measures the pressure, and it's going to show that the pressure of the lower esophageal sphincter is at resting really high, where at resting it should be low. And since there is a baseline increased lower esophageal resting pressure, the lower esophageal sphincter does not relax, leading to the accumulation of food and resulting in that bird beak appearance. So once you diagnose the barium, you do a barium swallow, you confirm and feel like it's achalasia due to the bird beak appearance, you do a manometry. The manometry shows increased lower esophageal resting pressure and confirms the diagnosis of achalasia. What are you gonna do next? If they ask you, you're gonna do a upper endoscopy. Why? Because achalasia results in progressive accumulation of food, and that results in metaplasia, just like that happens in GERD. So achalasia can result in malignancy as well. So you need to do an upper endoscopy to rule out malignancy in case of achalasia. So question can be asked. I'll also give you all the sample questions that are going to prepare you for the scenarios. So if they ask you that the achalasia has been confirmed, they did manometry, what is the next best step? The next best step is to do an upper endoscopy to make sure that achalasia has not led to the development of malignancy. And why does achalasia lead to the development of malignancy? Because achalasia causes progressive metaplasia of the lower esophageal epithelium, just like gastroesophageal reflux disease does. So all this is the description of what everything I told you guys. We'll also give it a rapid read. Dysphagia can be classified as oropharyngeal esophageal. You're gonna have to see the symptoms in order to classify that. Once you've classified that, you're gonna do the testing that is required for each. For oropharyngeal, you do a modified barium swallow. For esophageal, you are then supposed to figure out whether it's either due to malignancy or achalasia, depending upon the symptoms. If it's achalasia, it's gonna be a rapid onset dysphagia to both solids and liquids, whereas if it's malignancy, you're gonna get progressive dysphagia plus a history of smoking, alcohol intake. So as it says, oropharyngeal dysphagia is difficulty initiating swallowing due to improper transfer of food from mouth to pharynx. It's neuromuscular disorders are the highest yield cause, like advanced dementia, stroke causing neuromuscular incoordination, advanced dementia causing neuromuscular incoordination, myasthenia gravis, which results in weakening of the muscles and contraction, since at the end of the day, the acetylcholine in the neuromuscular junction is really reduced, so the oropharyngeal muscles do not function properly, so that can also lead to oropharyngeal dysphagia. Patients with oropharyngeal dysphagia can also have associated coughing, choking, nasal regurgitation. So this is one of the ways you are going to identify that, and that can result in aspiration, obviously, since the food enters the windpipe, and that aspiration can lead to pneumonia. So the diagnostic studies, video fluoroscopic modified barium swallow esophageal dysphagia. I told you guys need to differentiate between either achalasia or malignancy as a cause. So the highest yield thing that is going to differentiate esophageal from oropharyngeal, esophageal dysphagia as a result of malignancy or as a result of achalasia is the onset and timeline. Intermittent progressive symptoms depending upon the underlying condition. So one more thing, achalasia can be progressive or can be uh, just at the start, like at the onset of symptoms, both to solids and liquids, it's confirmed achalasia. But if it's progressive, you have not ruled out achalasia. But now you have two differentials, either achalasia or squamous cell carcinoma or adenocarcinoma as a cause. But how are you gonna then differentiate it between the demographic of the patient? So if they say dysphagia is just at the start for both solids and liquids, it's achalasia. If they say it was progressive in nature, then you see the patient population. If the patient is a smoker, alcohol abuser, then you go towards malignancy as a cause. But if the patient does not have these demographics, then you can go towards achalasia. Another thing, if the patient has a severe amount of weight loss, then you go towards cancer as a reason. If the patient has a small amount of weight loss, because achalasia results in inability to properly intake food, so that also results in weight loss. But if the patient has a minor weight loss, you go for achalasia. So basically, achalasia and esophageal cancer need to be distinguished at the end by the patient population. So esophageal dysphagia to solids generally reflects mechanical obstruction. Symptoms can be progressive from solids, which suggests developing stricture or cancer, or intermittent. Evaluation of dysphagia. So we'll discuss this flowchart as well, and it's gonna make really good sense to you knowing that you have done everything else that I've explained. So you get a patient with dysphagia, you ask if the patient has stuck food sensation in the chest, or regurgitation of food, or choking or coughing during the swallowing process. If the patient has stuck in the food sensation, it's esophageal dysphagia. If the patient has regurgitation, choking, coughing, it's oropharyngeal. So let's assume it's coughing, choking, aspiration, it's oropharyngeal. Then you're gonna do a modified videoscopic barium swallow to visualize the defect during the swallowing process. If it's esophageal dysphagia, now you see the nature of progression. If it's progressive from solids to liquids, it's mechanical obstruction mainly, which means either the patient is developing a cancer that is leading to obstruction, or the patient is developing a stricture that is causing initially just obstruction to solids and now to liquids. So in this case, you do an upper endoscopy, since upper endoscopy is going to visualize the lesion, and then you do a biopsy. If the dysphagia is at the start to solids and liquids both, that says that it's most likely achalasia. So you do a barium swallow followed by manometry, because barium swallow is going to give you the bird beak appearance as shown here. And then after that, once you visualize the bird beak appearance, you confirm the diagnosis of with manometry, which shows increased lower esophageal resting pressure. So this is, it seems complicated, but it's really easy once you get the hang of it. So now we move, and once you've diagnosed achalasia, if they ask you what is the next best step, it's to do an upper endoscopy in order to confirm that the achalasia has not led to the development of cancer. So now we come to achalasia, and we're going to do it in some detail. So it's chronic dysphagia to solids and liquids both, and it can cause regurgitation, because the regurgitation comes from the lower part of the esophagus, not from the mouth. It's not gonna occur while eating. Once the patient has eaten, he's gonna be resting, and then he can get regurgitation because the food is just accumulated here. That is the reason for regurgitation. Heartburn, why? Because just like gastroesophageal reflux disease, the food is accumulated there and it causes metaplasia and heartburn. So as I told you guys, achalasia is usually misdiagnosed as gastroesophageal reflux disease for years, and after the patient fails medical treatment, that is when they are usually diagnosed with achalasia, because the symptoms usually overlap with the heartburn. The patient is going to complain that I feel chest heaviness and stuck food sensation and heartburn. So he's being treated for gastroesophageal reflux disease as a initial diagnosis, but the patient does not get better, and then upon further investigation found out the patient had achalasia. Weight loss, it's really minimal, not comparative to the cancer weight loss. It can be 2 to 3 kgs in the past 6 7 months, that's it. But if it's cancer, it's gonna be really pronounced. Manometry is gonna show increased lower esophageal resting pressure. That is it. Barium swallow is gonna show the bird beak appearance. I told you upper endoscopy should be done after the diagnosis is confirmed. How are you gonna treat it? Myotomy or pneumatic balloon dilation. What does myotomy does? Myotomy is basically you resect the lower esophageal sphincter muscle, so the lower esophageal sphincter then is allowed to relax. Pneumatic balloon dilation, you forcefully dilate the lower esophageal sphincter. So botulinum toxin injection, it also relaxes the smooth muscles. Nitrates and calcium channel blocker. So what if the mainstay of treatment is myotomy and pneumatic balloon dilation? That is what you need to remember. Achalasia causes chronic dysphagia to both solids and liquids, mild weight loss. That is why I am pronouncing it again and again, that weight loss does not automatically mean it's cancer. You need to see the patient demographic and see the amount of weight loss. Mild weight loss is not necessarily cancer. Other symptoms include chest pain and heartburn due to accumulation of food. Therefore, many patients are initially diagnosed with GERD. On average, patients have symptoms of approximately 5 years before receiving a diagnosis of achalasia. So this is the main point I was trying to highlight again and again, that usually misdiagnosed as GERD. So if you see a patient with chronic dysphagia and you feel like it's GERD, make sure you do rule out the diagnosis of achalasia. How? Because you're gonna because the patient is gonna say that the food seems stuck. The patient is gonna have chronic history of GERD. The patient is not responding to medical therapy for GERD, that is proton pump inhibitors. So you need to keep in mind that it might be achalasia. That is how you move towards the diagnosis. So GERD and achalasia should be kept hand in hand. Achalasia is due to impaired peristalsis of the distal esophageal sphincter. This prevents food or liquid from passing down, resulting in increased hydrostatic pressure, just as shows the food is accumulated here, so it causes increased hydrostatic pressure. And once the hydrostatic pressure becomes more than the resting pressure of the lower esophageal sphincter, a small amount of food does pass. Being in the upright position increases the pressure, so it helps in swallowing. So this is also one of the symptoms that the patient says, but it is also a symptom of GERD. The patient of GERD is also going to say that if I eat food and lie down, I feel like the food is causing burning sensation and I get regurgitation. And same goes for the patient of achalasia. So that is also a point. Manometry is the most sensitive test that is going to diagnose the resting pressure. So bird beak appearance is shown in barium esophagogram. That is barium esophagogram shows bird beak appearance at the junction. Pseudoachalasia. What is pseudoachalasia? Pseudoachalasia is basically, so anything that causes you to feel like it's achalasia, but in reality is not, it's not achalasia. All these scenarios are termed as pseudoachalasia. What can cause you to believe that it's achalasia but it's not? For example, the patient has dysphagia to both solids and liquids at the start, and you feel like it's achalasia, but the patient also had a significant history of smoking, alcohol abuse, and it turns out that the patient also has a significant amount of weight loss. So what are you going to do in this case? Since it's not progressive, the dysphagia is both to solids and liquids at the start, so you feel like it's achalasia, but all the other things point towards that the patient demographic is that of a cancer patient, and you do an investigation, it turns out to be cancer. This is termed as pseudoachalasia. You felt like it's achalasia, but it was not achalasia. So that is just pseudoachalasia. So what can cause you to differentiate pseudoachalasia from cancer? Tobacco use, because that supports a diagnosis of cancer. Significant weight loss, that supports a cancer diagnosis as well. The regional lymph nodes being swollen up, a widened mediastinum. Mediastinal lymph nodes are swollen, they are big, that also points towards the cancer of diagnosis. So everything that points other than towards the diagnosis of achalasia is going to help you differentiate achalasia from esophageal cancer as a diagnosis. Endoscopic valuation can differentiate between achalasia and pseudoachalasia. That is why even if you do diagnose achalasia, you are gonna do a upper endoscopy to rule out a cancer. In achalasia, this evaluation usually shows normal appealing esophageal mucosa and a dilated esophagus with possible residual material. It is generally possible to easily pass endoscope through the lower esophageal sphincter, unlike in malignancy. So basically, this is everything that we discussed. Pseudoachalasia is something that feels like achalasia, but it's not. And how are you going to know? With the patient history and demographic. Treatment of achalasia is, I told you, highest yields myotomy and pneumatic balloon dilation. If the patient cannot undergo surgery, you resort to the botulinum toxin injection or calcium channel blockers. This also relaxes the smooth muscles. Now, this also relaxes the smooth muscles. This basically paralyzes the smooth muscles, and calcium channel blockers relax the smooth muscles. However, all these treatments should be considered once the diagnosis of achalasia is confirmed and you have performed an upper endoscopy, because achalasia can also cause cancer. So there was a scenario, and they're also discussing this was basically a really confusing scenario where the patient had pseudoachalasia. So this patient had progressively worsening dysphagia with solids and liquids both, and barium swallow reveals a dilated proximal esophagus, basically a Bird-Beak appearance. This presentation is consistent with achalasia. Achalasia is an esophageal motility disorder that can be idiopathic or due to cancer obstructing the lower esophageal sphincter, pseudoachalasia. So basically, pseudoachalasia is when you get the presentation of achalasia due to obstruction of the lower esophageal sphincter that is not due to inability of the lower esophageal sphincter to relax, causing the appearance of achalasia, but actually it's cancer. The patient had several risk factors suggesting pseudoachalasia. As I told you guys, these ones: tobacco, significant weight loss, swollen lymph nodes. Like this patient had tobacco use, alarm features like rapid symptom onset and significant weight loss, widening of the mediastinum caused by tumor metastasis in the regional lymph nodes, that is the mediastinal lymph nodes. So this is how you differentiate. So basically, when everything aligns, that is when you make a diagnosis. Everything, the patient demographics, the findings, the history, everything. Achalasia is chronic in nature, so the patient should be having chronic dysphagia to both solids and liquids for progressively at least for 2 to 3 years. It's not like the patient was just fine and within 6 months he developed dysphagia to both solids and liquids. He was a smoker, he was an alcohol abuser, and had significant weight loss. You do a barium esophagogram, you get a Bird-Beak. This is not achalasia, because nothing aligns with achalasia. The patient had a significant weight loss. The patient developed symptoms so quickly. Since, on the other hand, achalasia is chronic, but this patient developed symptoms so quickly. The patient is also a smoker, so obviously you get the gist of what I am trying to say. So it also says that you, after whenever you confirm achalasia, even with manometry and barium esophagogram, you still do an upper endoscopy to rule out cancer, because achalasia can cause cancer as well. So myotomy is recommended for treatment of achalasia with low surgical risk. If the patient cannot tolerate surgery, you go for calcium channel blockers or botulinum injection. So diffuse esophageal spasm. I've written here episodic achalasia. This is the best way to describe diffuse esophageal spasm. So how are you gonna differentiate diffuse esophageal spasm from episodic episodic achalasia from all the other symptoms? So since this is diffuse esophageal spasm, the location of the spasm would not be only isolated to the lower esophageal sphincter. It can occur at any part in the esophagus. And one more thing, what differentiates it from achalasia is that the lower esophageal sphincter resting tone is normal. So basically, the patient gets episodic achalasia in which he cannot ingest solid and liquids at the onset of the symptoms. The symptoms then after a certain amount of time go away, and this is the episodic nature where the patient gets dysphagia to both solids and liquids at intermittent stages throughout the day or throughout the month. So what is the first investigation you're going to perform in this case? The first investigation that you would perform in this case would be you're going to do a barium esophagogram, and that would not show you any signs of bird beak appearance. Instead, it's going to show you a corkscrew pattern of the esophagus. What do you mean by a corkscrew pattern? A corkscrew pattern basically means that you're going to have a narrowing, then a relaxation, narrowing and a relaxation. I'll show you a diagram as well. Once you identify this pattern, the diagnosis of diffuse esophageal spasm can further be confirmed by performing a manometry. So basically the investigations are just the same, come in the same order as that of achalasia. First you do a barium esophagogram, then you do a manometry, and after that you can perform endoscopy, upper endoscopy as well, to visualize what is causing or visualize any other disease that may occur as a result of diffuse esophageal spasm and food retention in the esophagus. So basically the corkscrew appearance would be like, so this is the high yield corkscrew appearance. As you can see, this is diffuse esophageal spasm. This is the normal part of esophagus. This is the spasmic part, spasmic part, spasmic part, normal, 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 spasmic part, spasmic part. So this is the appearance of the esophagus. You're going to be visualizing on the barium esophagogram, and then you're going to do a manometry to confirm it, just like as you do in achalasia. So now the question comes that after you do the manometry, what are the gonna be results like? So manometry is gonna show you that you're gonna be having non-peristaltic contractions of the esophagus. What do you mean by non-peristaltic contractions? The peristaltic contractions occur in a rhythm and a flow. There is contraction of the esophagus followed by proximal contraction, distal relaxation, and this process moves forward. As the esophagus contracts, the distal part starts to relax in order to move the food forward. But in case of diffuse esophageal spasm, this flow of contraction would not be present, and instead you would be getting diffuse contractions at random locations of the esophagus. So this is the finding that you're gonna see on manometry, that is non-peristaltic contractions that are not associated with normal peristalsis. So this is gonna confirm the diagnosis of diffuse esophageal spasm. So what are the treatments? So you cannot do any sort of surgical operation because the entire esophagus is involved. So instead you're gonna give medical therapy that relaxes the smooth muscles, that is calcium channel blockers in this case. So what are the differentials that you are gonna have with diffuse esophageal spasm? The first one is, you might think that it is achalasia, since there is sudden onset of dysphagia for both solids and liquids, but the intermittent nature is gonna rule this out. Since diffuse esophageal spasm comes and goes away, the patient's gonna have problems, then it's gonna be fine, then gonna have problems again. But achalasia is chronic in nature, the problem persists. And the other thing is, you'll be easily able to visualize the difference on esophagogram. In achalasia you get the bird beak appearance, whereas in this you're gonna get corkscrew appearance. Nutcracker esophagus is another differential, which is evidenced by excessive tone in the lower esophageal sphincter, whereas in case of diffuse esophageal spasm, the lower esophageal sphincter tone is going to be normal. Instead you'll be getting intermittent contractions or spasms of the esophagus that are going to be evident on the esophagogram in terms as corkscrew appearance of the esophagus. So now we're gonna do a discussion regarding everything we just read, and it's gonna be a really productive discussion. We're gonna see alternative differentials and everything as we change the questions as well. 73-year-old Alzheimer's patient has lost 3 kgs in the past 8 months. So 3 kgs in the past 8 months, not that much, minimal weight loss. Chronic history of GERD. Okay. So GERD can be also a reason behind the development of uh, esophageal cancer, as it causes metaplasia of the lower esophageal sphincter and cause adenocarcinoma of the lower esophageal sphincter. Caretakers report regurgitation of food following meals. Next best step. So caretakers report that there is regurgitation of food following meals. Note that it's regurgitation of food following meals, not during the eating process in itself. So this is basically esophageal dysphagia. This is not oropharyngeal dysphagia. So when there's a Alzheimer's patient involved, usually you get a hint that since it might cause neuromuscular incoordination, it can be oropharyngeal dysphagia. But in this case, it's esophageal dysphagia. So what is the next best step? So we need to know a hint of what the diagnosis might be in order to decide what's the next best step. So the patient has lost minimal weight, has chronic history of GERD, and the caretakers report that there is regurgitation of food following meals. So this sounds like that the patient this sounds like the patient is not having any cancer, since the weight loss is not indicative of a cancer, but the chronic history of GERD does point towards the fact that the patient might have cancer. But remember, the chronic history of GERD is also a really big symptom of achalasia as well. They have not mentioned any presence of progressive dysphagia or just dysphagia to solids or liquids. So most probably the diagnosis here is not that of a cancer. The diagnosis is most likely achalasia. First, we narrowed it down that it's esophageal dysphagia. Now, we have other differentials which include achalasia, esophageal cancer, stricture formation, or a diffuse esophageal spasm. The diffuse esophageal spasm is not the answer because the symptoms are not intermittent in nature. When it comes to cancer, it's not cancer because the weight loss is not indicative of cancer. And now we're left with achalasia and another diagnosis, which is stricture formation. But stricture formation is also unlikely because stricture formation requires a caustic insult, like a patient who tried to ingest something that caused damage to the esophagus. So we're left with achalasia as a differential diagnosis. So the next best step would be to perform a barium esophagogram that was gonna show a bird beak appearance, and then we'll follow it with manometry, and after that we'll do an upper endoscopy. So chronic history of GERD, and if we read it here that the patient had lost 10 to 11 kgs in the past 8 months, so that would point towards cancer, and we would not perform barium esophagogram. Instead, since we have a diagnosis of cancer, we're gonna do an upper endoscopy to visualize the lesion. So if in this question they would have mentioned how the nature of dysphagia was like, dysphagia to solids or dysphagia to both solids or liquids, the question would have become much more easier. But even then, the cancer is being ruled out and all the other differentials are also being ruled out, despite the fact that we do have a chronic history of GERD, plus the chronic history of GERD is also indicative of achalasia, as it is usually misdiagnosed as GERD. So the next question is for 40-year-old female, complains of food stuck in chest and heartburn, can drink but has problems with solid food, uh, has not lost any significant weight, was a smoker 10 years ago, smoked 3 cigarettes a day for 7 years. Next best step. So the smoking history is not significant since she has already quit smoking 10 years ago, and she's relatively young, and the smoking history was 3 cigarettes a day, which is not that much. One pack a day is a significant smoking history, but this is not significant. So the patient has heartburn and food stuck in the chest. She was initially able to drink but now has problems with solid food as well. So this is progressive dysphagia going on in here. But we do not have, and progressive dysphagia points toward either formation of a stricture or a cancer, but there is no significant weight gain, weight loss, which rules out cancer as a differential here. But we are left with now is either achalasia or stricture. Now, what is the difference between achalasia and a stricture? Achalasia causes sudden dysphagia to both solids and liquids, but that is not always the case. And it can only present with initially with only just liquid and then progress to solid. So this, you guys need to remember that achalasia is not always just dysphagia to solids and liquids at the start. Usually it is, but not always. So we are left with achalasia and stricture, but this patient shows no signs or symptoms of a developing stricture. Why? Because there is no history of insult to esophagus. History of insult includes ingestion of a caustic substance like a drain cleaner that can lead to the development of stricture. So the only differential we're left with is achalasia. So we're gonna perform a barium esophagogram as the next best step in this case. One more time, if it were cancer, she would have lost significant weight and would have significant smoking history, but she does not have that. And since we have esophageal dysphagia, the other differentials, the one that stands the most is achalasia here. Even though it is progressive, the dysphagia is progressive, but we're only left with achalasia, and there is no significant weight loss, which can also be present in achalasia, just 2 to 3 kgs in 7 to 8 months. So we're only left with achalasia. That's the main thing. A 70-year-old male chronic smoker has lost 8 kgs in the last 6 months. This is significant, and the chronic smoker history is as well. Complaints of dysphagia to both solids and liquids since the past year. Chronic history of GERD. Barium esophagogram shows bird beak appearance. Diagnosis. So one thing that you need to remember here, that this patient has a lot of alarm signals, alarm signs for cancer development. First, he is really old. Second, chronic smoker. Third, significant weight loss. Fourth, complaints of dysphagia to both solids and liquids since the past year. They have not mentioned if it is progressive or not, so this one is not included in the alarm signals. But the age, the smoking history, and the loss of significant weight loss. So the barium esophagogram points toward achalasia, but we feel like that there are a lot of risk factors for uh, development of esophageal cancer. So what is the diagnosis here? The diagnosis here is pseudoachalasia, even though it sounds like achalasia, but since the risk factors are really pointing towards cancer, that's why we do not go for achalasia, we go for pseudoachalasia. Why? One more thing is that complaints of dysphagia to both solid and liquid since the past year. So achalasia develops really slowly. It takes years. Like the patient has a history of food stuck sensation for at least 2 to 3 years, and before that he has a history of chronic GERD. But this patient just developed dysphagia just a year ago. So these are all alarm signals. So this is most probably esophageal cancer. So diagnosis is pseudoachalasia, and the next best step would be after barium esophagogram in this case would be to perform an upper endoscopy to visualize the lesion, because in this case the obstruction would not be because of increased lower esophageal sphincter tone. It's gonna be due to either most probably adenocarcinoma obstructing the lower part of the esophagus, leading to the development of these obstructive symptoms, and also leading to the development of this bird beak appearance. Bird beak appearance is basically obstruction at the distal end of the esophagus, which causes everything proximally to expand. So it can be either due to achalasia or due to obstruction. So in this case, it's due to obstruction by a cancer. So the diagnosis is pseudoachalasia, and you are having cancer in this patient, most likely lower esophageal adenocarcinoma. So we'll move on to the next question, that is, we have a 60-year-old male that is a chronic smoker and has uncontrolled hypertension, had a stroke 6 months ago, can walk and talk but has weakness in the right arm. So what does the weakness in the right arm mean? Usually it means that the problem is in the left part of the brain, and as you know, the combination usually goes like uh, lower extremity or upper extremity plus face of that side. So the right arm if he has a weakness in the right arm at the moment, so it usually means that he also has some weakness on the right side of the face that might not be that prominent. But yeah, the combination is usually the upper extremity with that side of the face or the lower extremity alone. That is what the sensory homunculus tells us. Let me just show you an example. So when I told you guys that the combination is either the upper extremity or the face, that side of the face or the lower extremity alone. So that usually coincides with the sensory homunculus. As you can see, the anterior cerebral artery, if that causes infarction, it results in weakness of the lower extremity. Whereas if the middle cerebral artery undergoes infarction, you usually have a combination of the upper extremity and that side of the face. So that is the reason that we conclude that if the patient has the right side weakness of the hand, then he must also likely have a problem on that side of the face as well. So the patient complains of choking and severe cough during food intake. Diagnosis. So this basically it's a high yield scenario for oropharyngeal dysphagia, and it is more prominent when they tell you that the patient complains of choking and severe cough during food intake. The choking is because the food is not properly directed towards the esophagus. Instead, it enters the windpipe and that triggers the cough reflex. So, what is the diagnosis? Diagnosis is oropharyngeal dysphagia as a result of stroke. What is the next best step? Obviously, when we conclude that the patient might have oropharyngeal dysphagia, we're gonna perform a barium swallow study in order to visualize the swallowing mechanics and where the problem lies. What is the dietary modification in this case? This is also a high yield question. The dietary modification is that you're gonna ask the patient to quit consuming liquids that are really liquidy. Basically, you're going to ask the patient to consume thickened liquids. That is the high yield word here, thickened liquids, because the more liquid in consistency the food is, the more chances of aspiration and it going to the wrong place. Instead, if you go for a thickened liquid, it's more likely the patient won't choke on it. So the next question is 60-year-old male chronic smoker with uncontrolled hypertension had stroke 6 months ago, can walk and talk but has weakness in the right arm. It's like the similar question above. Now has fever and productive foul smelling sputum. CBC shows leukocytosis. Chest X-ray shows right lung middle lobe consolidation. Cause. So basically this is yet another high yield question which tells you that oropharyngeal dysphagia as a result of stroke can lead to aspiration pneumonia. So this patient has aspiration pneumonia as a result of oropharyngeal dysphagia. How do we know that this patient has aspiration pneumonia? Because the patient had a history of stroke and now has foul smelling productive sputum, which is a high yield finding in aspiration pneumonia, aspiration of the oropharyngeal contents that result in formation of uh, can also result in the formation of abscess, lung abscess. So that in that case, you also get foul productive smelling sputum. CBC shows leukocytosis, which further confirms, and the chest X-ray shows the right lung and middle lobe consolidation. So the right lung is a high yield place for aspiration. Why? Because the bronchi of the right lung, when it divides from the trachea down to the lungs, the right bronchi is usually at an angle that causes more, that is more prone to developing aspiration as compared to the left lung. The bronchi is in such a position, I'll draw. So if this is the trachea, when it comes to the right lung, the bronchi is positioned like this. Whereas when it comes to the left lung, the bronchi is more at an angle. So more chances of aspiration happen on the right side of the lung. So that is another reason that points that that is another clue that points toward the fact that this is in fact aspiration pneumonia in this case. So the cause is obviously stroke, oropharyngeal dysphagia leading to aspiration pneumonia. So another question would be like 40-year-old female chronic heavy smoker for 20 years. So this significant smoking history, suicide attempt 2 years ago via drain cleaner ingestion, has had problems with food regurg after meal since last year. Now has problem with eating solids as well as liquids. So this was progressive in development. Initially, she only had dysphagia to liquids, now has problem with both solids and liquids, and also had problem with food regurg. Get severe heartburn after meals, has lost 5 kgs in the last year. So this is not a significant amount of weight loss that we would conclude comes from cancer. So next best step. So what is the diagnosis in this case? The most viable diagnosis that we have is that of a slowly developing stricture. So initially, because we also have a history of caustic drain cleaner ingestion that causes caustic injury to the mucosa of the esophagus. So in this case, the patient developed a stricture that was initially less severe, so only had problems with liquids. Now the stricture got even more narrower, so now the patient has problems swallowing both. And the heartburn is due to the accumulation of food in the esophagus. Has lost 5 kgs. Obviously, since the food intake has been affected, that is why you have 5 kg weight loss. So, even though the patient has a significant smoking history, the age is not that um, in accordance with development of esophageal carcinoma. Usually, the patients are older, so you can dismiss this significant smoking history and go more towards the diagnosis of uh, a slowly developing stricture in light of the brain cleaner ingestion history. So to next best step would be to perform an upper endoscopy to visualize the structure. Why are we not performing a barium esophagogram? Because we do not have achalasia in our list of differentials. Achalasia as a main diagnosis here. If we felt like it was achalasia, we could have done the barium esophagogram. So that is why we are not doing that. The only two things we have in only the one thing that we have is the slowly developing structure, and we need to visualize it, so we perform an upper endoscopy. If it were a scenario where we suspected cancer, then similarly we would still do an upper endoscopy. If we expected that the patient might have achalasia, we would have done barium esophagogram. So we now move on to eosinophilic esophagitis. So sounds really complicated, but in reality, it's not that complicated. Basically, this is hypersensitivity to certain foods of the esophageal mucosa. That's it. So the patient is also going to have a history of other atopic processes, such as the patient may have a history of asthma. The patient may also have a history of other hypersensitivity diseases such as eczema. So a patient with a history of atopy is going to present to you, and he's going to say that certain times after ingestion of certain foods, for example mayonnaise, for example eggs, or other things that contain protein, usually it's a hypersensitivity reaction to of the esophageal mucosa to ingested food triggers, usually proteins. Like I just gave you two big examples. The first one is mayonnaise, the second one is eggs as well. So the patient is going to say after consumption of certain foods, the patient gets a sensation of food getting stuck in the throat, in the chest, as well as heartburn due to the hypersensitivity reaction, and the patient feels like he's gonna vomit. He gets a sensation of reflux. Basically, this is all due to the ongoing inflammation of the esophagus as a result of hypersensitivity reaction towards the food triggers. So the patient has a history of atopy. The patient is usually young, and since it is triggered by certain foods, it's not chronic in nature. Usually, it gets aggravated by ingestion of certain foods. So, what is gonna confirm the diagnosis? Firstly, the patient may say that after he quits those foods, he gets well. And another way you can confirm the diagnosis is by performing an endoscopy, and that is the high yield finding that the endoscopy is going to show. This is termed as trachealization of the esophagus. Basically, you get multiple white ring-like exudates on the esophagus. So this is the highest yield finding here. So how are they going to give you a scenario? The first way they're going to give you a scenario is they're going to give you a young patient with a history of atopy that has intermittent problems with dysphagia, and they're going to show you the endoscopy findings and ask you of what the diagnosis is and what is the treatment, what is the next best step. So the diagnosis here is gonna be in that case eosinophilic esophagitis, and the treatment is gonna be dietary modification as well as swallowed fluticasone, which is a corticosteroid, and it's gonna ease down the inflammation. So that is gonna be the treatment for that case. They can also give you a scenario where they give you a patient with a history of atopy and give you this high yield classical finding of the patient getting intermittent bouts of dysphagia upon ingestion of certain foods, and they're going to ask you what is the next best step for diagnosis. You're going to say upper endoscopy to visualize the trachealization of the esophagus. So basically this is all it is to be associated with eosinophilic esophagitis. I'm also going to give you two example scenarios. So the next up in line, we have pill-induced esophagitis. So basically, it's also inflammation of the mucosa of the esophagus, but the reason in this case is a a pill that causes either direct injury to the mucosa or causes inflammatory reaction, either direct injury like acid effect or disruption of normal protection like NSAIDs do. So in case of eosinophilic esophagitis, you get the trachealization finding on the upper endoscopy, but in case of pill-induced esophagitis, you're gonna see ulcers followed by normal mucosa, then ulcers like if you consider this as esophagus, you're gonna get an ulcer here, you're gonna get an ulcer here, you're gonna get an ulcer here, and the rest of the space between the ulcers would consist of the normal mucosal tissue. So this is gonna tell you that there has been some sort of direct injury to the mucosa that has resulted in the formation of these ulcers. So what drugs can cause this direct irritation of the esophageal mucosa? Tetracyclines, anything that blocks the production of prostaglandins like NSAIDs. Bisphosphonates are really high yield for causing esophagitis like alendronate, risdronate. I'll also give you an example. It's really highly advised that following the ingestion of bisphosphonates like alendronate, you stay in an upright position for some amount of time to prevent the reflux of these bisphonates, because the reflux is highly associated with esophagitis. Others like potassium chloride, iron. So the mechanism of injury can be direct injury due to acid effect or disruption of protection like NSAIDs. So the history is gonna include that the patients do not have any prior history of esophageal disease like GERD or anything like this. And after the ingestion of the pill, the patient suddenly develops uh, odynophagia, that is a painful swallowing, since you develop a mucosal injury and ulcer, so that you get painful swallowing. If you try to swallow, you get retrosternal chest pain, typical. But what is going to hook you towards the diagnosis is that a normal patient with no history of any esophageal disease, GERD, or substernal chest pain, or odynophagia suddenly develops all these symptoms. And if you take a closer look to the history, you'll either get the patient just started antibiotics, the patient just had a knee sprain and started NSAIDs, or the patient is already taking bisphosphonates. And this is going to tie you on to the diagnosis of pill-induced esophagitis. So diagnosis is clinically made, but endoscopy can confirm it, and it's gonna show discrete ulcers with relatively normal mucosa in between. You're gonna get an ulcer, normal mucosa, ulcer, normal mucosa. That is gonna show that the patient has been having injury to the mucosa due to some external agent. That is why injury followed by normal mucosa injury. So one more high yield thing that I wanted to mention was left atrial enlargement is associated with hoarseness of voice because it causes compression of the recurrent laryngeal nerve. So left atrial enlargement can be seen in mitral regurg, it can be seen in left ventricular diastolic dysfunction, left ventricular failure, that causes left atrial enlargement as a result of blood backing up in left atrium. So that can cause hoarseness as well. Why did I mention left atrial enlargement here? Because the pill-induced esophagitis is common in mid-esophagus, because that is the place where the aortic arch causes compression of the esophagus, as well as an enlarged left atrium, which also causes compression of the esophagus at the mid-esophageal plane or mid-esophageal location. So this is where usually you get the ulcers developing, because that is the compressed area, and whatever drug you eat, it's most likely, like if I demonstrate, like if this is the area, this is the esophagus, and this is the aortic arch that is causing compression. So if you intake anything, so this area is more prone to getting in contact with that substance. That is why you usually develop ulcers at the mid esophageal area due to the compression caused by the aorta. So that is why you get ulcers from pill-induced esophagitis at this location, due to the compressed esophagus coming in contact with the drug. So we move on to the esophageal perforation now. The biggest giveaway when it comes to esophageal perforation is the history of the patient. There are only three scenarios. The most high yield ones are only three scenarios where you can keep esophageal perforation as a differential. The first one is a patient who just underwent endoscopy. So during endoscopy, trauma to the esophagus can lead to perforation. During endoscopy or just right after endoscopy, if a patient develops the characteristic symptoms, yeah, you can safely assume it's esophageal perforation. The second one is a patient who's been consistently vomiting and retching. So that can lead to full thickness tear of the esophageal wall, that is termed as Borhaeff syndrome. So in this case, you can safely assume that the patient might have had esophageal perforation as well. So basically, the full thickness tear of the mucosa of the esophagus results from high level retching and vomiting, and especially if a patient tries to hold the vomitus and prevent the vomiting, the increased hydrostatic pressure that develops in the esophagus can result in a full thickness rupture. So this is the second scenario, a patient who's been really vomiting a lot and retching a lot. If that patient develops the characteristic symptoms, it's most likely esophageal perforation. And the third one is esophagitis. So how is esophagitis gonna tie into this scenario? An example can be a patient who has been chronically using either like bisphosphonates that cause esophagitis, or a patient who has been having a history of chronic esophagitis as a result of eosinophilic esophagitis, a patient who's been consistently like they might give you a endoscopy finding of trachealization of esophagus, and the patient having chronic symptoms of this case, and patient also having a history of atopy, so that you know that the patient is having problems with eosinophilic esophagitis, or a patient who's been chronically using NSAIDs, or a patient who's been chronically using alendronate, that is bisphosphonates, and then that patient develops the characteristic findings of esophageal perforation. So this is how you make sense of the esophageal perforation. These, you need to remember these high yield patient demographic findings, like endoscopy, a patient with chronic vomiting, and retching, a patient with chronic esophageal inflammation, that is esophagitis. So the high yield findings that you're gonna get when the esophagus undergoes a full thickness tear, the contents of the esophagus are gonna leak into the thoracic cavity. So the first thing that leaks is air. Air from the esophagus enters the thoracic cavity. So you're gonna get subcutaneous emphysema, that is crepitus under the skin of the chest or of the neck. Since when the air leaks, the air it's termed as subcutaneous emphysema, where you get air trapping in the subcutaneous tissue of the thorax. So you're gonna get crepitus or crepitation sounds upon pressing the neck or the chest, since the air leaks out. The second sign that can be, we're gonna go in order of how things work. So first, the air leaks out, you get subcutaneous emphysema crepitus, that is termed as Haman sign. After that, the fluid that might be present in the esophagus can also leak into the thoracic cavity, so you might get unilateral or bilateral pleural effusion. Since the fluid leaks down in the thorax, you get a effusion, and if you try to get the pleural effusion, if you aspirate the effusion out, it's gonna be green in color. The green color signifies that it is gastric in origin, or it is coming from the GIT. That is what the green color indicates. And sudden development of infusion in a previously patient who has been asymptomatic further amplifies that this is as a result of esophageal perforation. And other symptoms, since the tear is usually in the esophagus, and esophagus lies in the substernal area, so you're gonna get epigastric or substernal chest pain. And since the fluid leaks out, it causes a inflammatory reaction in the thorax that results in systemic signs of fever. So if we go in order, as the esophagus ruptures, you get the air leaking that results in subcutaneous emphysema and crepitus sounds. After that, the fluid leaks in, and that results in pleural effusion. That is, if you aspirate it out, it's going to be green in color. After that, since the fluid leaks out and causes an inflammatory reaction in the thorax, you get the signs of fever. And since the location is substernal, you get substernal chest pain, or if the tear is lower in the esophagus, you might also get epigastric pain. So these are all the findings in order of how the stuff happens. So what is the chest x-ray gonna show? First of all, the chest x-ray is gonna show you a widened mediastinum. Why a widened mediastinum? Let me draw this out. So if this is the esophagus, and this is the stomach, and this marks the diaphragm. So when esophagus ruptures and the fluid leaks out, you're gonna get filling of the fluid around the esophagus. That is gonna show as widened mediastinum on the chest x-ray. As the fluid leaks, it also enters the lungs that are present just on the either side of the esophagus, and that causes you to develop a pleural effusion as well. And since the air also leaks out, you're gonna see pneumomediastinum, which is basically air in the mediastinal space. So these are the three high yield findings. First, the air leaks out, it causes pneumomediastinum. The fluid leaks out, causes effusion. That is gonna be evident on the chest x-ray as whitening of the lung fields as well as blunting of the costophrenic angle. So if this is the lung, this is the costophrenic angle right here, and in case of pleural effusion, the angle gets blunted due to the accumulation of fluid. So the angle becomes like this. You're not able to appreciate the angle, and it gets on x-ray, it appears white. So you're not able to appreciate the contrasting angle like this. So that is what indicates that effusion has developed. Firstly, you're gonna see whitening and whitening of the lung fields, and second, you're gonna be able to appreciate the blunting of the costophrenic angle. I'll also show you that. So this is a high yield example of pleural effusion. As you can see that on the left side, you can appreciate, if you follow the cursor, you can appreciate the costophrenic angle here. But on the right side, and there is, you might assume this is a consolidation. What tells you that this is not a consolidation? Consolidation is usually confined to the lung lobes. So the marking or demarcation of the consolidated lobe is really definitive and hard. But in case of effusion, you don't see a specific demarcation. It's just whitish, and it's basically it has a gradient. But when it comes to consolidation of a lung lobe, you're gonna get a really finely marked lobe. You'll be able to appreciate that it's a specific lobe that has been demarcated really well. But in case of effusion, it's just gonna be a gradient, and as you can appreciate, there is no costophrenic angle on the right side because the fluid just seeps down as a result of a pull of gravity on it, and it just blunts the costophrenic angle. So this is another image that helps you appreciate the costophrenic angle. So they've marked it really well here. This is the costophrenic angle, which in case of, this is also costophrenic, this is the costophrenic angle. So in case of fusion, this gets blunted, and that is how you know it's an effusion. So the high yield findings on the chest x-ray, the mediastinum would be widened. You would get pneumomediastinum, air in the mediastinal space. You're gonna get you're getting a fusion, and you'll be able to appreciate that via blunting of the costophrenic angle, and you're also going to get air in the thorax, that is pneumothorax. So the CT scan helps you appreciate the esophageal wall thickening and mediastinal fluid collection. So what is going to confirm the diagnosis? The diagnosis is only going to be confirmed once you confirm that whatever the patient puts inside his esophagus is leaking into the thoracic cavity. How are you going to do that? You're going to make the patient drink a water soluble contrast, and you're going to visualize it, and you're going to be able to visualize that the contrast is leaking from the esophagus into the thoracic cavity, and that leak from the perforation on visually when seen is what confirms the diagnosis of esophageal perforation. So they're gonna give you a scenario and ask you what is the next best step. The next best step is gonna be esophagography with water soluble contrast, in which you're gonna be able to appreciate the contrast leaking from the esophagus. So what is the treatment? The first treatment is, since the patient does not now have an intact esophagus, you're going to ask the patient to not drink or eat anything. That is, you're going to NPO the patient. You're going to give the patient IV antibiotics to prevent any infection and proton pump inhibitors. And the most highest yield one is you're going to do a surgical consultation, because you need to fix the tear. So all in all, what is the next best step in the management of the patient? That would be a surgical consult, if I have to put it that way. So we'll also give it a read as well. But before we give it a read, I'm gonna give you some